Thank you all for staying to the end. Why Mike Chernew last? Because I said all 450 people here in the room would certainly stay to hear the co-creator of value-based insurance design if we put him in the cleanup spot. Not only is he a Harvard professor, an IOM member, MedPAC commissioner, member of the Essential Health Benefits Committee, member of the Commonwealth Fund Commission, an advisor to CBO and CMS. He also coined the term VBID,
which no one likes.
Right, which now no one likes, and now we're going to Connecticut and getting beat up. But I think why I asked Mike to close this out, and I differ with David that Michael will always be part of the VBID Center family. But the neat part about this is Andy Chasen's in the room. So think about Mike, and less so myself, that we always said from the beginning, before this was even called VBID, that we were the tortoise in this quality improvement and cost containment rates. And many of you have seen flashes in the pan of ideas that may save the healthcare system or reduce quality. And we've been doing this a very long time. And I asked Mike to close out because he's been steadfast in his unwillingness to say the things about VBID that people want to hear without the evidence that you're hearing today, that it actually does what it's supposed to do in terms of quality, or maybe not will save money. And after he testified the first time in front of Congress and was unwilling to say that value-based insurance design in almost any form would not save money, he was described as the guy who's done the best job to slow the adoption of his own idea. So to continue the slow adoption of our own idea, I'm pleased to give Mike the podium to close out today's conference. Michael.
I get introduced a lot. That was probably the best introduction. I'm speechless. So I'm going to run through a lot of slides so we can end at 4 o'clock, and I want to summarize. I really enjoyed what Thomas said about science fiction. The first VBID conference, some of you may have been here, it was in January 2006. It was snowy. People weren't sure what was going to happen. And I have to say, in sitting here today, I am stunningly impressed at the ability of both the private and public sector to take the basic ideas behind VBID and make it a reality in terms of developing the technology, developing the clinical knowledge, bringing together the sort of venture capital, bringing the health. It's stunning to me. But all of that's, despite everything I've said about it. I'm going to really cover some themes that you've heard today and then maybe say a few quick things about where I think we need to go. But you heard really clearly that the main issue that we face policy-wise today is that healthcare spending is rising as a share of GDP, and that's not a healthcare issue anymore. It's a national issue. I've heard it described as a national security issue because our debt's unsustainable. So the entire country, in many ways, hinges on our ability to control healthcare spending, which brings me to my first point, which controlling healthcare spending growth is imperative and sort of the VBID subtext. Let's try to preserve value and not kill people. And I will say there is a greater chance than I would care to admit that as we move through the policy environment going forward, we will end up killing people in our zeal to control spending, which we have to do. And I think Mark's sole mission, since I've known him in the beginning, is just to, not kill people. It's actually better than that. But he would say variously, keep health in the healthcare policy debate or some other version, to keep the eye on the reason why we're in the healthcare sector in the first place. And that's sort of how VBID started. And I think you heard a lot of that today through the evidence and other types of things. So I'm going to skip the definitional issues largely, but I do want to say when we talk about spending, we're generally talking about spending at a national level, a overall spending, not spending per disease, not spending for a particular service, but overall spending. There's some nuances about who is spending that money. How much do we care about overall spending or federal spending? Because federal spending involves taxes, whereas overall spending involves people paying out of pocket. There's a big debate about that, which I would love to have, but we're not going to have it now. And Stu Gutterman said this extremely well in his talk, so again, I'll be brief. We don't have to really cut spending. We mostly have to lower the rate of growth in spending over time. If we could cut spending, that's great if we could do it and preserve value. But our fundamental policy challenge is to control the rate of spending growth over time. So the first question I wanted to ask was, who's going to control spending? These are patients. So I'm an economist. I believe in the power of the market. They're going to clearly be involved. These are physicians. Physicians are the captain of the ship, and obviously the healthcare system, physicians, providers in general are going to be central to this. But the group that I think is actually probably most important in how we're going to address this spending problem is this is broadly the purchasers, the insurance company executives, the employers, the policymakers that are responsible for designing the system in which the physicians and the patients are going to operate. So I believe that in order to get the physicians and the patients to do what they really should do, you need to have a system which both incents them and educates them to do that. So the question becomes, how are we going to do that? I have three options on the board. I don't think they're mutually exclusive. One is payment reform. I'll talk a little bit about payment reform. I spend a lot of my time now thinking about payment reform. And as many people here today have said, this has to be integrated with value-based insurance design. Consumer strategies, such as VBID, and then organization of medical practice, which I'm not going to talk about very much. And I guess I should say now, my general belief is organization of medical practice is central. It won't happen unless we change the payment reform and the consumer incentives. So I view it as the mechanism by which the two fundamental levers work, as opposed to a standalone pillar. And so I'm going to talk about payment reform and consumer strategies mostly. So it turns out to be the case, and I'm glad you stayed to hear me say this, if you want to pay less, it helps to actually pay less. And you see this all through the ACA. The ACA lowers provider payments through lower updates. It pays less for managed care plans. No one knows exactly how providers are going to respond. Historically, they offset lower prices with higher volumes, but you can't make up for prices below cost with more volume. So it's really unclear what's going to happen. There's a lot of worry about quality. There's a lot of worry about access. And I don't know anybody who wakes up thinking that the solution we have going forward in this country is we just need a better fee-for-service healthcare system. I'm waiting. Maybe the person's going to jump out. No. Because I've shamed them. That's what the problem is. All the excitement around payment reform involves bundling payments, grouping payments across services and providers in episodes, say for a hip or a knee or a heart attack or something, or a global payment, which used to be called capitation when that wasn't such a horrible word to say. So now it's sort of a bundled payment. You see aspects of this in the ACO, and I really give a lot of kudos for the Center for Innovation for exploring different ways of doing this, although I'm sure there's a long way to go. And again, people worry about quality when you do that. They worry a lot about risk transfer. How much risk can the providers take? But I think the biggest questions involve things like, how are we going to set the rate? How are we going to update it over time? My biggest complaint with the whole system right now is they've built this system that requires a fee-for-service system against which to judge spending so they can set the rates for the system they want people in. But if everyone moves into the system they want them in, it's not clear what the rates are going to be from the fee-for-service system. And thinking through that actually is going to become pretty important. But the broader things, and I'm a big supporter of payment reform, and all of those things, it's important to understand payment reform doesn't easily address consumer preferences. Consumers have different preferences, they want different care. It's hard in a payment reform system to deal with that. I was over at the UK in the summer, and they have a system in their word, how can we make it more consumer responsive? How can we bring incentives to consumers into the system to make the system to respond to what they want? And there's a real fundamental policy question in this payment reform debate about whether or not we allow patients to buy up, whether we allow people to pay more to get more. In a premium support system, the answer is clearly yes. In a global payment system, the answer is not so clear whether we allow them to pay more. And that, I think, is going to be a big debate going forward. The other thing that hasn't been discussed a lot today, in part because it's a VBID, not a payment reform conference, is this broad idea of bundled payment has the real potential to hamper innovation. If you are not careful in how you set these payments and these payment updates, you really could stem the incentive to innovate because the payment bundle umbrella doesn't rise enough to allow access to new things that are really very good. And we have to ponder that. And I think one advantage of a VBID system is it might allow us to promote innovation in a system that is fundamentally going to involve some level of payment reform, which brings me to the consumer strategies. So the big questions, and I want to leave you here with these big questions. The first one is, what role should patients play in determining how healthcare resources are allocated? This is a fundamental policy question you hear all the time, where some people view the entire debate as between the payers, often government, and the providers. We'll give them this much money, the providers will do what they want. Not clear what role patients should play. And if you think the patients should play a role, how variable are their preferences? how much do we have to worry about a system that responds to these consumer preferences? And if we think we should respond to consumer preferences, you can see I think that we do, what role should financial incentives play in patient decisions? And that's a really complicated question, because if you allow financial incentives to matter, some people will not do things you want them to do. Or will get different things than other people get, and some of that will be related to income, and that makes us all uncomfortable, and it's made Mark and I uncomfortable from the very beginning. In fact, I will say, just parenthetically, one of the ideas behind VBID is there's a lot of areas we want patient preferences to matter, but there's some really important things. We know what they are. They're quality measures. Peggy left, but the NCQA has a whole series of quality measures. Other people have quality measures. For those things, maybe we don't want financial incentives working the exact same way, and that's really part of where VBID came from. So there's a lot of consumer strategies, high deductible health plans. There's a big push to reform the way Medicare supplemental insurance policies are to prevent people from buying or tax them if they're buying really generous supplemental insurance plan. There's a lot of work on tiered networks. You heard a lot of the stuff that's going on here today about plans that involve incentives and tiering networks. There's a move to balance bills. Sometimes it's called private contracting or even basic premium support. There's a lot of ways to do patient incentives. The problem is there's this basic, I'm an economist, I like markets, I like market allocation of resources, but there's a basic challenge to the market paradigm, which is, unfortunately, cost sharing reduces the appropriate use of services as much as the inappropriate use. It cuts out things that we believe fundamentally are good. Preventive services, valuable pharmaceuticals, and it can lead to disparities. Low-income people are more affected than high-income people. So although some incentives are important, you have to worry about these downsides, and that's really where VBID comes in. What I call VBID Classic is the... That's new. I just coined that. We went away, they brought us back. Is to align copays with value. I want to be clear, it's not just lower copays, that's align copays, and I think Jeff talked about some of the challenges in doing that, but it's about aligning copays with value. But also there's aspects of reference pricing models or tiered networks. If they're based on value, they would fit under my VBID umbrella. If they're based on cost alone, then they wouldn't, and that's really the challenge in figuring out what value is matters, and I'm thrilled with the energy in this room of people trying to figure out how to do that better and communicate that better. So my summary of the entire day/world is I do believe bundled payments have the capacity to control the spending growth problem that we have if we have the courage to maintain updates in a way that will do that. And I'm not sure we have that courage. Talk to Senator Daschle. They may fail to accommodate patient preferences, which is a big concern. They may discourage innovation, which is a big concern. So we have to think about how we can use cost-sharing strategies to complement that. Now, I do believe cost-sharing strategies could work, particularly at reducing payer spending, but they transfer risk. We have to worry about that risk transfer. They could exacerbate disparities. VBID is, in many ways, that sort of idea or tool that fits in there that allows you to use patient incentives, but not so bluntly that these problems become insurmountable. And that's really where we're trying to go with VBID. There's a whole bunch of other strategies. I'm very supportive of a large number of them. I have to tell you honestly, I think in the grand scheme of things, if not coupled with these basic incentive changes, I think they're going to have a small impact. I think they will be important in the context of some of these broader changes, but I think right now we have to focus on the role that we're going to do with payment and patient incentives before we think we can just transform the way practices communicate one way or another. I think Thomas said this clearly. Things like IT are really important in the context of broader reform. So the general next steps, most of which have been said, is to integrate the benefit design and payment innovation type things, to align patient incentives and provider incentives. Others have said that better than me already today. To continue to research and continue research to define and measure value. Often, it used to be everything I got was, you can't do VBID, we don't know how to do it in back pain. I'm not sure we can do it in back pain, but we can sure do it for diabetes and a bunch of other conditions, and continue research to measure patient responsiveness. Kevin talked about this in terms of wellness. Teresa talked about this in terms of patient response to incentives. Obviously, research on provider response is important as well. And as we move down the road, it is stunning to me how far we've come in 5 years, and I give a lot of credit to that, to Mark's unboundable energy. So it is actually truly unboundable. No, it's not a word, but it's all right. Insurmountable. So we can have a contest, words to describe Mark's energy. So, in closing, I do want to give my own thanks to all of you for coming. It really has been a remarkably encouraging day to see the level of energy around this basic area. I want to thank all the people that, Jean, Jen, and Tracy, all the people that helped make this happen. Obviously, Mark and the University of Michigan, which has really helped a lot with the general promotion of this, and I hope that all of that continues to move forward, because in the grand scheme of big policy issues, trying to weigh the role of patients in a healthcare system that has a lot more control on pricing is fundamentally what we have to think about. And that can't be done without the type of leadership that's here on campus. So anyway, I really was wonderful to be here, and thank you all very much, and turn it back to Mark.